episode 31 of BioBalance Healthcast. I'm Dr. Kathy Maupin.
And I'm Brett Newcomb, and today we're talking about fatigue.
Well, fatigue is the most common thing I hear about all day. It was more common when I was in my GYN practice, but now I still hear it as my second most common problem for menopausal women and premenopausal women.
Well, I think it's a chronic problem in the United States. People are always stressed out, they're always tired, they're always exhausted. In my practice, I hear constantly from people about how tired they are and how much they don't have the energy to do the things that they're supposed to do. And there are a lot of reasons.
Well, they're overbooked.
They're overbooked, they're overscheduled, they're overconnected. I mean, constantly checking your email.
Yeah.
You know, and people
problem.
argue. I mean, even in sessions, you know, husband and wife will be sitting there arguing about something, and one of them will check their, message. Somebody just got a text from the kid, or somebody just got an email, and it's like, you need to separate this out. You need some time when you turn that stuff off and pay attention to each other, and you won't be as stressed or as tired. So I come at it from a perspective that involves stress and overbooking and overcommitment. You come at it with other information that I don't necessarily have.
That's true, and if you look at the medical information, the medical journals, the medical books, fatigue is the biggest differential diagnosis. Now, differential diagnosis means what are the many things that can cause this one symptom? And that's how doctors look at it. Let me see this list. Well, the list's like 25 things that can cause fatigue. And there's some big diseases that can cause fatigue. So before I address it, I usually send people to their internist, make sure there's no medical illnesses. If I think there's a psychological issue, I have them go to counseling.
Right.
Or I suggest that they learn to say no, which is much cheaper than counseling. But when they get called by church to do yet one more thing.
People need counseling to learn how to say no. It's a big issue.
No, I don't have time. I'm tired. And it always reminds me.
And not give too much information. Say no and shut up.
That's
Don't say
right.
no because
That's your
or
best
no
advice.
maybe.
No
Just say
and shut
no.
up.
Yeah, and then shut up. And that's what I tell people. You need to learn how to say no, and then don't give any more information. Absolutely.
Because that's the lead in.
We have the same issue in my business because we talk about cluster symptoms. And so there are so many overlapping symptomologies that you have to then differentiate or distinguish among to say, well, is this more OCD? Is this more anxiety? Is this more depression? Is this more...
But even ADD in your business, people who have ADD
Yes.
and they haven't been treated and they
Yes.
get to 40 and they've always worked really hard at managing their ADD and
Yes.
they're starting to lose their hormones, they're getting
And
tired.
then they're reluctant to take medicine or allow their child who has ADD to take medicine because they say, well, I survived. Just like the old guy that says, well, I didn't go to school and look at me. Like, well,
but if
okay.
they had diabetes,
Yeah.
would you keep
And
them from taking insulin?
That's the question I always
that's
ask.
exactly the same thing.
Every time. Or if they had cancer, would you avoid treatments for that just because it's a medicine?
Most children want to be good at school and want to be able to sit still. And since I can't sit still, I totally understand that theory. Yeah. And you need to have something to help you sit
boys in
still and
particular.
pay attention.
School teachers like quiet, orderly, in-row children that are attending and focused. And boys have trouble with that, especially
And most
in grade
doctors
schools.
are ADD.
That's
obsessive
good
compulsive.
to know. Well, there you go. Those are good combinations.
Yeah, it makes a good surgeon. But the things that cause fatigue and the things that I think about the minute somebody comes in and says that, and I've already ruled out medical problems because they've usually been to 10 doctors before they show up in my office. I ask them about their sleep. Insomnia is one of the reasons that you can have fatigue during the day because daytime sleepiness is what happens if you don't sleep well at night. That's one of the things that can be related to testosterone, but isn't always. Then hypothyroidism is another hormonal problem. I check their thyroid. If you have a low thyroid, you're tired all the time. So that's another thing. The stress we discussed, hypoglycemia is one that people don't think about. I go over their diets and they have a completely carbohydrate diet. And then they wonder why they're exhausted at 3 o'clock.
Or they're diabetic already.
Right.
And then they're fatigued as a result of the mood swings that come with the insulin and sugar balances.
High sugar, low sugar, all day long make you exhausted. That kind of fatigue sounds like at 3 o'clock, I have to eat something really sugary just to get through the rest of the day. And then when I get home, I pass out. 6 o'clock, 8 o'clock, I'm gone. That's diabetes or hypoglycemia until proven otherwise.
Is a major consideration. I mean, that has to be evaluated for and test run to see. I have clients that come in, though, and say, well, I think I have chronic fatigue syndrome because that's a a term that they interpret to be a global expression of really tired. Like the old Madeline Kahn,
Right.
I'm so tired.
Well, that's in Blazing Saddles. I hear that in my head every time the song that she sings
Yes.
is about, I'm so tired, and
Yes.
she sings this song, and she's has good reason to be tired.
I could actually quote that song.
Yeah,
for
I
you.
don't think you should
I
probably.
probably
on
shouldn't.
this.
Yeah.
But that's.
But yeah, so they come in and they say, I must have chronic fatigue syndrome.
Mm-hmm.
What good will counseling do for that? Can you help me? And I say,
Well,
learn to say no.
chronic fatigue doesn't mean.
Yeah.
Chronic fatigue doesn't mean chronically fatigued. It's a name for a different kind of process.
Okay.
And chronic fatigue can mean low cortisol, okay, an adrenal failure from too much stress, or it can mean a chronic infection, and in generally it's that, usually monovirus.
Okay.
And monovirus can become a chronic infection that plagues you after you've had mono. You think you're over it, but you never get back to normal. And there's a test for that. It is a test for, it's called the EBNA test. And we test it all the time and find people who I treat with hormones, they're fatigued, they should be completely better after getting the hormones balanced
Right.
and their thyroid replaced. And then they end up being, I'm still tired. So I check the EBNA. That's kind of the last diagnosis. When it is positive, then we have chronic fatigue. That requires a medication that's not even out yet, called Valsite. It's an IV medication that actually does kill the monovirus. And in my way now, I just treat people with optimal hormones, and that improves their immune system so they can kill that virus. So most of my patients in the end feel so much better because I've given them all the hormones they need, and with time their immune system starts killing this virus and they get over it. But that's not what we're talking about today, because that's a whole different kind of diagnosis.
Well, and
Fatigue is,
it
just-
leads into another causative factor, which are different medications that people might be on.
Right.
And as you were sitting here explaining all that stuff, it strikes me because doctors have to be so aware of so much chemistry. And it's important for the doctor and the pharmacist to have information about what you're being treated for by whom and what you're being given as a medicine by whom, because all of these overlapping mixes cause problems in and of themselves. And you can be fatigued as a consequence of taking beta blockers and blood pressure medicine, diabetes issues that you may have medicine for to treat that, but then a sidebar consequence of that is that you're fatigued.
The medications that do cause fatigue are beta blockers that we use for lowering blood pressure or treating an arrhythmia. And arrhythmias are big as we get older, so that's often a medication we can't change. We just
Right.
have to deal with the fatigue. But for blood pressure, there's so many things out there. We often can lower blood pressure with something besides a beta blocker. So
all these things are possible, and they're not the focus of your practice, but they're the things that your practice has to be conscious of. So if I come to you as a new patient, and I may have some of these histories, I may be complaining of fatigue, I may be complaining of low libido, I may have diabetes or hypo or hyperthyroidism one way or the other, and I present myself to you and say, can you help me? What do?
the first thing we do is ask you to get some blood work and see if you really have anything I can help you with.
Okay,
Then
that's a
we-
lab test that I
that's-
go to my lab.
It's it's a bunch of lab tests that you feel like I've just taken all your blood, because it's a lot of lab tests.
So I go to your website, and I schedule an appointment, I download the forms, and that...
And we send you a form for the lab, so you can go to the lab.
Okay, all right.
So you get the lab, I look at it before I ever, agree to be your doctor, because I need to be able to help you. I'm not having someone come in that I can't help. To me, that's just a waste of
If you
their
can
time.
tell from those results,
I can
it's not
usually
a
tell.
good fit for you.
And I look at their history. The next
Right.
thing is the history they fill
Okay.
out and send it to me. So I look at both things together. So that's necessary. Then we sit down and go over the history, which is huge. Knowing what started first, how it started. Was there a trauma? Was there a head trauma? Was there a divorce? Was there some other emotional problem that started this, or was it turning 40?
What about like sleep apnea or a
Well,
history of sleep problems?
If I get fatigue and insomnia that does not sound like a hormonal insomnia, then I send people to a sleep study to see if they need a CPAP machine, see if they have narcolepsy, which is sleepiness during the day, falling asleep at work. I had a mother who had that, and that was very hard to convince her to be treated because she thought she was fine, except she fell asleep at dinner or in a conversation. So that kind of thing needs to be treated. Then
Or driving the car with
or
a kid
driving
in
the car, and of course that happened, and that often happens.
And then
so
suddenly they discover they need to be treated.
it's my responsibility to find that out and make sure that it is treated. So when I'm looking at this, I do those things. If I think it's cardiac, as we're talking, hormonal and cardiac, then I deal with sending them to a cardiologist. And for women, I ask for an ultrasound of their heart while, like an echo, which is what that is, while they're on a treadmill. That's the test women need to see if their heart has an arrhythmia, if they have some kind of compromise of their vessels.
As opposed to men don't need that, generally?
Men don't usually get, a treadmill test is usually good enough for men,
Yeah.
but women need this other test. And generally cardiologists all know that.
Oh, okay.
So I send them for good referrals, because referrals are the key to making sure that everything gets treated. So I do that. I then go over their history of their symptoms and their labs. Their labs tell me whether their adrenals working right, if their pituitary is working right, if they have testosterone, if their ovaries are failing, and then one by
So
one.
you have a really good diagnostic picture before you make the decision to use hormone replacement pellets.
Right.
And if you then decide together with the patient, this is a protocol they want to have,
Decision.
then how do you decide how much of which pellets to give them? Because you do multiple hormone replacements.
Yes.
So the next decision then is the chemistry set balance. Do you have standard rules of thumb for men versus women on what you start with or how much you start with?
Let's address women first.
Okay.
Women have their pellets replaced every 4 months. So I have to determine a dose that will both make them better and replace their hormones for 4 months and last long. So I figure out an estradiol dose. Usually an average dose would be 25 milligrams of a pellet. I increase it for someone who has a lot more hot flashes. I then usually look at the symptoms for testosterone. If they have more testosterone symptoms, I then go to testosterone and I increase it. If they exercise every day, I have to increase the testosterone. I look at every aspect of their life and determine what dose of testosterone and estradiol will make them back to normal. Then I go back and I try the dose that I've prescribed. It's not always perfect because everybody's metabolism is so different. I bring that patient back at 3.5 months, right before their next dose, and I ask them, what's better? What's not better? And by the symptoms that are not better,
So you
I
make
can
those
tell.
adjustments.
And I've also at that point drawn another lab and I look at that.
Good. So you can see a visual comparison and you get an anecdotal or self-report comparison about how they are feeling.
Right. And that's very important because oftentimes certain people need more testosterone than others.
All right.
And that's how we decide is it's an art and a science.
We were obviously not finished with our conversation about fatigue, so we're going to have another podcast which addresses more of this. If you have questions about what we've done already, you can reach us at podcast@biobalancehealth.com, or you can read my blog at brettnewcomb.com.
And if you'd like to know more about BioBalance Health or bioidentical hormones, visit our website, biobalancehealth.com, or call my office, 314-993-0963.